Miscarriage, also known in medical terms as a spontaneous abortion and pregnancy loss, is the death of an embryo or fetus before it is able to survive independently. Miscarriage before 6 weeks of gestation is defined as a biochemical loss. A habitual miscarriage is the term given when a woman has had more than 3 miscarriages, and it affects approximately 1 to 2% of women. Once ultrasound scan is done, or histological evidence shows that a pregnancy has existed, the used term is clinical miscarriage, which can be early, before 12 weeks, or late, between 12 to 21 weeks. On your regular health TV talk show, The Physicians, we'll be discussing habitual miscarriages in obstetrics. Stay tuned. It's another day with The Physicians, where your health is our business. My name is Dr. Martina Agberie, your regular anchor on this program. I'm not alone. I'm with my co-host,
Dr. Bemuna Yusuf Kadri. It's always a pleasure to be here. And of course, you all know your health is our business.
It will always be our business because we are the physicians. We'll be discussing habitual miscarriages in obstetrics. As a medical practitioner and who is also well-grounded, knowing that you went through your residency, house officers, work, and all those ones, even after medical school, how in the obstetrics and in the obstetrics and gynae clinic, and how many of those cases did you see?
A particular woman that had resource.
Okay.
Yeah, so she has resource, and resource, resource positive, resource negative. So anytime she gets pregnant, that doesn't sit well with our own resource type. Compatibility. And because of that, the first time, so she kept having, that recurrent issue. And people, in fact, the reason why she came to the hospital was, it was now like a gang up in the area that she's a witch, she cannot keep pregnancy, she cannot, she's not fit for marriage. And that was her first pregnancy. And she was actually really getting pregnant, pretty soon. And so when she came, and they now just that one test.
That it did.
Just one. So, and I'm just asking myself, sitting down now, I'm like, why is it that these are the things that people should really actually do before they will get married? Resource compatibility is something you should, don't just look at just genotype and end it there. Resource, if you are going to have children.
Apart from before getting married, I think is what every woman should do, even before conception.
Just to know
where you belong. Welcome back. If you have just joined us here onto your regular health TV talk show, The Physicians, where your health is our business. Today we'll be discussing habitual miscarriages in obstetrics. And with me in the studio, we have a renowned obstetrician and gynecologist. He is the MD CEO of Louis Med Specialist Hospital in Lagos. He's no other person than our renowned Professor Anthony Bamigboye. Prof, you are welcome to our program.
You're welcome, and thank you, Mrs. Uncle, for having me.
You're welcome, Prof. Always a pleasure having you on board.
Thank you so much indeed. Habitual miscarriages. That is a very interesting topic that you chose.
Yes.
And everybody, my viewers at home, want to hear something about it.
Maybe first and foremost, just give us an overview. When you talk about habitual, then miscarriages, what actually do you want us to know about it?
We call it miscarriages because, you see, I want to delineate abortion from miscarriages.
Exactly.
Abortion was what we were taught in school in those days. But over time, we realized that we are dealing with human beings, with clients. So let's call it a more accessible name. That's how we ended up it as habitual miscarriages.
Now that you made that mention, what we were taught in school,
Yeah.
what comes to mind is we used to say inevitable abortion.
Inevitable abortion.
So inevitable abortion is actually a miscarriage,
Yeah.
right?
Yeah.
Okay.
You
Go
know,
ahead.
it's part of what can
Lead to
A
miscarriage.
miscarriage,
Yes.
yes.
Okay. Okay. So go
You
ahead.
see? So we have to modernize what we call it. So that's why we involved this concept of habitual, not recurrent
Abortion.
abortion. Yeah.
Abortion.
So it's now
Okay.
Because abortion
habitual.
sounds criminal. It sounds like a crime.
A crime,
Yeah.
yeah, exactly.
Yeah.
Sounds like a crime. Not many people want to
Yeah.
accept it.
Yeah.
So talking about habitual, it means it's something that is frequent,
Yeah,
right?
it's like a recurrent
A
thing.
recurring thing.
Well, but we don't call it recurrent or habitual if it's not more than 2 miscarriages.
Okay.
Because miscarriages on its own could be very common indeed in women. Many couples will undergo miscarriages when they're pregnant in about 1 to 2% of cases. So when you have a recurrent miscarriages, you ought to have 2 or more than 2 miscarriages. It means the third one. When you are on the third one, then we call it habitual. And when you have a third miscarriages, the chances that you have another one,
It's
which
high,
is the fourth one, is very high.
Okay.
So up to like 25%.
Wow.
So that's why it's something to treat, to hear about from our viewers at home.
Okay.
So, Prof, you know, when you said habitual miscarriage, and it has to be more than 2, meaning it's from your third that would get to know
It's habitual.
habitual.
Yeah.
2 things I want to ask here. How close, if you have, is it miscarriage that is once a year, and then the second one is the second year, and then the third one is the third year before you say it's habitual?
Or within 1 year.
Or is it within 1 year? So the frequency, I want to know that. Then what are the things that can cause habitual miscarriage?
Thank you, Dr. Memunant. We do not place any time frame on how many miscarriages you will have, how often you have it. No.
Okay.
The moment a pregnancy test is diagnosed and the ultrasound confirms it, and the woman is less than 20 weeks.
Okay. So that is the time
in
frame.
Nigeria,
That's
that's
the
one thing that I was not very clear about. In the UK, where I practiced, fetuses that are 20 weeks or more can survive. They are called viable fetus. But if it's less than 20 weeks, they are not viable. So we kind of determine miscarriages from 20 weeks or less.
Okay.
Or less. Now, in Nigeria here, we're not sure. It depends again where you are. When you are in Abuja, maybe 25 weeks to maybe 24 weeks. When you are in interior, I won't mention names now.
Yeah.
In the interior,
villages, yeah.
Maybe 28 weeks
Yeah.
or so.
Why do we have such a different? Why do we have such?
Because of
Is that
our
a standard?
because of our healthcare system, our healthcare system is a bit low, like in the third world that we are. Whereas in the first world, 20 weeks babies do survive. Babies that are
Okay.
less than 500 grams,
Okay.
they do live.
Okay.
So miscarriages of 500 grams or less than 20 weeks is what we term as 1.
Okay.
All right.
Okay.
So if you have a repeat of that is 2. The third one,
It's
then we
habitual.
term it
Habitual.
habitual. Yeah.
Okay.
And the causes.
The possible causes.
The etiology of miscarriages, of recurrent miscarriages. First of all, it could be things that has got to do with the genetic composition of the fetus or the embryo of the baby or the fetus. The babies that are not well formed, there's something we call karyotyping, or
Okay.
the chromosomes are not well formed. There's one called translocation of chromosomes. There's another one called deletion, or any form of abnormality in the genes will cause a miscarriage. So we can find that out as part of our investigations. Then we have problems again with the uterus, the womb. If the womb is poorly shaped, whether the wombs could have something we call septum, or they can divide into 2.
Seriously.
Yeah, they do happen. So when you have that, then then where the embryo is staying is not conducive for the growth, and then it will find its way out. That is that. Then we have issues of the hormones. If the hormones are not good, the hormone, for example, that causes PCOS,
Sure. Yeah.
then they are not good for the baby. Then the baby may demise. We have issues of infections. If you put SCI in inside of the private part, and it finds its way up there, then it can cause a miscarriage. Then we have the issues of the integrity of the uterus. If the cervix is soft, if it's the one we call incompetent cervix. And then there are a lot of stories that are around that. If you have diseases that are metabolic in origin, diseases like, again, diabetes is there, things again like thyroid is there, they can also cause miscarriage. Yeah.
Wow. Is there anything, like, we're talking about the risk factors? Does age have anything to also do with it?
Okay. I think if I may conjecture that the risk factor again would be issue of previous miscarriages in your mother or parent. So that is where we have things like autoimmune diseases, the soft tissue disorder, the one that will ensure that the cervix is not competent. So if you have there are some people, if you pull their skin, it has lost its elasticity.
Okay.
So those ones, surely the cervix again can also have incompetence.
Okay, so before you came in, Memuna and I talked about resource incompatibility.
Resource incompatibility. That is autoimmune, as I said, the immune system problem. Immune system problem is like the one that you have said. It's a very potent one. It happens a lot. When we are in high school, ladies and gentlemen at home, when we're in high school, many of us, had undergone miscarriages or either induced abortion or whatever it is. We underwent that, and then we're supposed to do our resource testing then. So if you do not do it, then you are at risk. Then if you do it and it's found out that you are RH negative, you're supposed to obtain an injection. If you don't take it, it means you have lost out. It means you are now immune against that blood type.
Prof, this is actually going to be very is a serious one, because for people that go for abortion, I don't think they actually are aware of the resource factor stuff.
They don't.
So because most people that go for abortion is just to ensure that they take out the fetus at that time and they leave.
Yeah.
And I doubt if doctors will counsel them or tell them that you are having this procedure and this is what we are supposed to do. I don't know if there's going to be something here, because most times they are not actually aware, and in future they become pregnant, and at birth, stillbirth, then you now find that it's because of the resource incompatibility. Welcome back. If you have just joined us, you're on to your regular health TV talk show, The Physicians, where your health is our business. We've been discussing habitual miscarriages in obstetrics, and in the studio are very renowned Professor Anthony Akinloye Bamigboye, a consultant obstetrician and gynecologist. Has actually been telling us a whole lot about it. He talked about the possible causes, and he did define what habitual miscarriage is all about. And before I went on break, we talked about resource incompatibility. I want to go back there, because what he said is, if you are actually resource negative and probably had an abortion, let's say like 20 or 5 years, some years before even getting married, and it wasn't detected at that time, you weren't given the injection, what it means is that at marriage, or when you would desire to have a child, you are likely or possibly going to come down with that challenge of having a child with stillbirth. So, Prof, I just wanted to just enlighten our viewers out there on this resource incompatibility and the possible things that can be done to actually prevent it. With that, you will now go into how we can be managed.
Thank you very much, my uncle. The thing about resource typing in women who are now pregnant is that when you have your first pregnancy, which you did an abortion for, the blood of the baby or the fetus might have diffused into the mother, And when they diffuse into the mother, that blood of the baby acts like an antigen. So the blood of the mother is now an antibody. It means a soldier fighting the antigen. So anytime you are pregnant again, that antibody
is there
still
to
there to fight. So when you are
Anyone
pregnant again, to fight. But the good thing is that it does not kill the fetus early. You kind of wait until 28, 26 weeks as a stillbirth. Then you can have a stillbirth. So a stillbirth may be taken as an abortion for those people. But for doctors, it's not. But for a stillbirth in a climate where there is a lot of health care, then you can still help. But in a climate like ours, it will be taken as an abortion. But technically speaking, it will not be defined as abortion again. However, when a woman is sensitized by exposure of the mother to the antibody or whatever, then the woman is supposed to obtain anti-D. We call it anti-D. We give it to them to prevent the attack of the antigen by the antibody. So the babies live, and then everybody claps for you. Oh, that professor knows what he is about. It's really not. Every pregnant woman must do RH typing. Everybody.
No, but Prof, this apart from every pregnant woman, before we even get to pregnant, is it not something that we can educate the public on? These days, our religious institution advocates that people go and do their blood typing, and all those things that comes with it. Should this not be incorporated into that? Because there's something Nigerians call premium tiers, and it has happened. It's better to prevent it than, of course, in this show, one of our biggest impact is people get to learn something new every day. So I would actually, on this platform, advocate that religious institutions, or those that don't have those religious institutions that encourages them, if you want to get married, don't wait till you want to get pregnant or until you are pregnant. Do your resource compatibility test.
Yes, I do agree with you, because that's why it's compulsory during the antenatal to always do resource compatibility. If you recollect, everyone is advised to do yearly blood check. So that's going to be incorporated as part of the test that we do, and most of the doctors do it. But I will also advocate that doctors at home should also endeavor that before abortion or during abortion, make sure that you have done your RH. So that those who need help should be helped.
Okay, so one very important thing that we should at least also take home from what you are saying is that it is not only because of a previous abortion. That is why the woman will come down with stillbirth. The woman is like to have the first child is always spared. The first pregnancy is always spared. But
because you don't have the antibody at that time.
Yes, you don't have the antibody at that time. So the baby comes out very well, but that antibody would have been deposited somewhere. This is actually the second baby, the second pregnancy. It is from there. So that's why you have some women say, but I had a normal child, I had a normal delivery. So why am I not having this problem? You begin to think of the home, family matters, yes, or banje, something is happening. You can have it 2, 3, 4 times consecutively like that until that injection is given. It will continue.
I've had miscarriage before between my first and my second, and miscarriages people talk about, is it not just miscarriage? Never you tell a woman, is it not just a miscarriage? Because you have already identified that you have a baby coming, and then you lose there's that bond, and you lose. They are so painful. You grieve, like every woman, if you've had a miscarriage, grieve over it, find closure. When that miscarriage happened, there was nothing I did, I wasn't sick, nothing, and we just had that kind of something. When we got to the hospital, the kind of test we ran, you think I'm going for a major operation. Like the doctors didn't want to have any repeat because they couldn't find a cause. There was no fever, there was no fall, there was nothing. So what could have caused, and of course, they at that point they were considering. That's why I'm asking this question, sir. I wasn't resource negative. I'm not even resource negative. There was a deliberation that could that be a possibility somewhere? Could it be? So, you know, when you are being, you not like experimental guinea people, like, because I'm a physician like them, they didn't want to take chances. Some that maybe, no, the overall consultant said, no, she's not resource negative. This is not habitual miscarriages, and this is her first. Watch and see subsequently if there is a repeat. And you know, that I really was cooled on resource compatibility and everything. So yeah, this is a big thing for women to really understand the impact of miscarriage of any form, not to talk of habitual miscarriages.
Okay, so you want to continue? We also talk about cervical incompetence.
Yeah.
Cervical incompetence is when you have an embryo in the womb or the fetus, and there's pressure on the cervix naturally from gravity.
Wow.
So when the fetus is able to expel itself from the womb outside through the cervix, because the cervix is weak.
Okay.
That's what we call cervical incompetence.
Okay. So,
and then cervical incompetence is caused mostly by the genetic makeup of the individual. Okay. People thought it's the trauma to the cervix, this and that. Yes, it could be a factor, but it may not be it at all. There are people who didn't do miscarriages before, or abortion, or surgical abortion, and they still end up with a recurrent miscarriage. So it's the composition of the person that is bringing it, mostly.
So how do we manage this, all these habitual miscarriages? What is it?
Well, thank you. Management is in two parts. Number one is investigations and ancillary investigations. The other part is the other causes, like you do genetic makeup, you check for sugar, you check for thyroid, things that can causing miscarriages. So that is one thing. Then the other one is to treat the problem itself. When a woman has miscarriages more than 2 times, the third pregnancy, she's very apprehensive, honestly. The anxiety is just too much. You will not be, and I'm sure you are, people who have had it before, you know what it is. Because you've already...
Fear of the unknown.
That with this baby,
bond with the baby.
The
bond is there. Even if it's 1 day old embryo, the bond is already there. I did a study in 1990s whereby I divided women into 2. Some of them, women who wanted to do abortion, and I don't normally do abortion then. And then I find out that I divided them into 2. The first group of women, I allowed them to do a scan, and they see the baby.
The baby's
this is the baby.
And that's a game changer.
Yes, and the second one, they did not see it. Okay, and I eventually did the outcome study, which was to see whether they are happy, the pressure score and so on and so forth. Doctor, is about the pressure score.
Yeah.
So the women who saw the babies on the scan, they were happier than those who did not see it, because the ones who did not see
did not connect,
did not close the chapter.
No closure.
No closure at all. So therefore, there's a bond there already. Now you want to prevent the miscarriage from happening. If you think it's incompetence, from the history you will know. Because they will miscarry about the same time. Okay. The first one at 12 weeks, and the second one at 12 weeks. Third one may also be at 12 weeks. So you take a rope. They would want to call a stitch. You grab the neck of the womb, you tie it nicely so that pressure doesn't fall on it and miscarry. That is one. Then number 2 is to do the blood test. There's some blood tests that encourages miscarriages. Things like anti-cardiolipin antibody, lupus anticoagulant, and the anti-nuclear factor. Those 3 blood tests, they are paramount for us to do, because one of them is actually a snake venom, the venom of viper. We use it to test the blood of the patient to see whether they are compatible or not. So if the blood of the viper venom is killing that other woman, it means that problem.
Okay.
But that's those tests we do it not
Sparingly,
sparingly here,
Yeah.
but abroad. Yes,
Yeah.
it's a must because things like SLD can cause it.
Exactly.
Yeah. Thank you.
And to our viewers again out there, we just want to say thank you for being part of our program today on your regular Health TV talk show. The physicians, I'm sure you all had a swell time. You got informed. Your knowledge got improved also from hearing what the Prof actually told us about habitual miscarriages. And for pregnant women, please ensure when you go for your antenatal, always ask that they check, at least for the first time, for the rhesus factor. I'm sure you're safe. There's always light at the end of the tunnel. On this note, I want to just say thank you again for being part of our program. My name still remains Dr. Martina Agbemi. Till next time, stay blessed.
Thank you very much, Prof. And of course, to our viewers, thank you always, for keeping, this time for us and making sure you are logging in and viewing us and listening to us. I'm sure you are much empowered as the way we are here in the studio. Please don't forget to follow us on all our various social media platforms, Twitter, Instagram, Facebook, and of course, please subscribe to our YouTube channel. If you've ever missed any of our shows, binge on our programs and you definitely enjoy yourself while getting empowered. Want to be like Prof, sitting down here talking to us and educating millions of people out there? You are just a click away. Send us an email and you'll be right here in the studio. My name remains Dr. Mimuna Yusuf Kadri. Until next time, remain blessed.